So this is a nice 75-year-old patient. She had left breast cancer, ended up getting the mastectomy and then eventual reconstruction with silicone implants below the muscle from 2007. So 600 cc's according to the patient. So as you can see right here, this is 75 below the muscle 2007 silicone implants. The right side is what I did first. This is the right mastectomy scar, and as you will see, this is the suture that's holding and orienting this mastectomy flap, because this is given the history of breast cancer, and for completeness sake and for an aesthetic flat chest closure on the right. I'm going to send this off to pathology. You can see how thin the flap is. There is an indentation. This is the part that was outstretched. This is the artificial nipple that she has. Now, as you will see, I removed the entire implant and the capsule, essentially all very large, sitting on the patient's chest. It was a grade 3 capsular contracture, super tightly adherent to the rib. You can actually see the rib mark. Now, as I was dissecting, there was an inevitable break in this capsular tissue right here. But all of this was plugged, and she's not getting drains. And as you will see, as I cut open, you will see what the internal contents are. So I'm just going to go ahead and take this, and you can see I'm very happy and content with how the whole dissection has gone. And this was done in a very meticulous, careful fashion. So as I'm going to go in, there was another small, you can see how thin the capsular tissue is here. As I go in, you will see how thick and inflamed and angry this tissue is. A 75-year-old patient, hurting on the left, grade 3 contracture on the right. So I'm going to cut this open, and you can see, look at this internal, like soft tissue. None of this spilled into the chest. I'm going to all contain this. I'm going to send this off to cytology, and you can see she had an MRI done. The MRI said it's not ruptured, and I just want to go ahead and actually I'm going to take the implant out and look at this. Is it indeed ruptured? So the MRI was wrong. Again, the MRI was wrong. Patient had a CT scan that showed possible rupture. And as I go in and I press over here, look at this. Look at the cream-colored implant, and look at this. What is this consistency of this and the liquid on the inside? And you see it's yellow, just like the traffic light yellow. And implants from 07, this is when they were introduced to be safe, if you will. So this is supposed to be the one that never ruptures, right? And so the one that says the gummy bear 600, just like the patient said, mentor. So again, look at the yellow color of this. I'm going to go ahead and put it here, and it is indeed, you can see, look at this. And there is nothing, as you will see, the shell is different consistency, and the inside did not spill. And I'm going to go ahead and let me put my instruments away. Actually, I'm going to leave them here because I don't want to cross-contaminate. I have a pair of sterile gloves, and you can see, look at this, 75-year-old patient. It's not fair for her to be living with this pain, contracture. And let's go ahead and see on the inside. Look at this. It's like a, I can literally squeeze this out. And I want to collect this as much as I can. And look at this muddy type of this discharge. It has a mustard/muddy consistency to it. Very thick capsule. I'm going to go ahead and collect as much of this, because I'm going to send this to a cytology, this fluid. Any fluid that's around, we talked about this yesterday, any fluid around the implant must be sent to cytology. And so this is where all of this, as you saw, none of this spilled into the chest. This is where 100% total capsulectomy is done. All nice, good, healthy tissue remaining behind. And I'm just going to collect as much of this as possible. So I'm going to send this off to cytology. I've seen this before many times. And I'm going to look at this. I'm going to literally all contained badness. And you can imagine what she was going through. This was literally super glued and plastered to her chest. So I'm going to go ahead and put this here. You can see it's an extensive area of dissection. Look at this. And I want you to go ahead and see all of this tissue. It's soft, all contained, none of this building of the chest, and very friable. So there you have it. Now I'm going to go ahead and remove my top sterile glove. We're going to take cultures of this as well. And remember, this goes to showing you the end block / 100% total capsulectomy. But even though this was not 100%, everything was contained. None of this flowed. It was one of the tougher cases that I've done in the last couple of years, as you can imagine, with the significant inflammation that was present. And I can only imagine how relieved she's going to be. So I have a brand new sterile pair of gloves. You can see how thin the flap is. This is to orient the 12 o'clock position. If I flip this over, you can see how thin the flap is. This is just the dermis. So there is no subcutaneous tissue. This is the previous reconstruction the patient had. So I took out what is the most compromised part of the left mastectomy scar. This is done on 100% end block left breast cancer stage 0. Remember, the capsule is going to be sent to pathology. The left mastectomy scar will be sent to pathology separately. And we're all very happy and content with how the whole dissection has gone. So I'm going to go ahead and cut this open. You can actually see this is the rib, and the fascia of the serratus anterior, the fascia of the intercostal muscle, all removed. And remember, over here, the MRI said this is an intact implant. And according to the MRI, this is supposed to be an intact implant as well. So let's see what it shows. So MRI was double wrong. So end block, the gold standard. And if I put my scissor here, you can see how relatively thin this is. So if I pull this out, this one doesn't have that curve that you see. And again, this is supposed to be the nicer, better, safer gummy beer. And you look at my glove right here. This is how thin the capsule is. There's calcifications over here, and as I go in, the not so gummy beer, if you will. Look at this, and the implant literally mushrooming out, and this goes to showing you that surveillance serial MRIs as recommended by the manufacturer. So this is 600 Mentor as well. And again, if I may, look at this. So, look at this again. So, a lot of learning points from this case. Number one, the MRI was dead wrong, not only on the right, but also on the left there. Number two, look at this implant is as yellow as mustard, if you will. This one is the disintegrated, not so gummy. There is nothing gummy about this, as you can see. So implants, the gummy bear that they use the F-150 to drive over and say these are safe, absolutely, you can see this does disintegrate. Who knows how long it has been like this. The right and left mastectomy scar will be sent to pathology to rule out the breast cancer, rule out any abnormality. The right and left breast implant capsule will be sent respectively to pathology. CD30 analysis, rule out lymphoma, rule out malignancy, rule out any abnormal pathology. This liquid on the right, along with some of these contents, are going to be sent to cytology to rule out that rare BILCL. And then cultures will be done for aerobic, anaerobic, and fungal. And most importantly, we'll see how this nice 75-year-old patient does, not only with the mechanical weight of the implant, 600 being taken off, and her breathing only improving because of the capsular contracture, severe on the right, severe on the left, with the pain on the left, along with all this inflammation, and how well she's going to do overall with her many symptoms of what are suggested of what is questionable illness. So there is a certain etiquette, certain process to this madness, if you will. You do not want to rush through the surgery and the next thing you know, this goes into the chest. You never know what you're going to find. Remember, both of these were supposed to be intact implants, so the MRI is not perfect exam. There's a false positive and false negative as well, just like with any test. 20 years from now, I cannot imagine this surgery being done any differently. If anyone challenges why an end block is key, none of the silicone spills into the chest, none of this grossly spilled in and basically contaminated the chest. I've done this many times before where the patient did not have any frank cultures that came back positive, but we'll see why this is yellow, why this is different, and I'm going to watch her very carefully and see how she does post-op minus these toxins. This is Dr. Khan, Executive Plastic Surgeon.